Obrigado, Joana. Bom dia. It's a real honor for me to be here today because this is such an important topic. Wherever I go, wherever I work in the world, this is a topic of utmost importance, but really the enthusiasm and the development of your work here on primary care, family care, basic services, however you want to say it or define it, it's really an inspiration for me, and I think you have much to teach other countries. So congratulations. And it's certainly a pleasure for me to be here as well. This is my second time in Brazil, but my first time on the beach. So it's really wonderful to be here and to be working with all of you. So, as Joana said, I'm going to talk about health financing. I noticed that everyone is interested in primary care, but also everyone is also interested in money and health financing. And so we're going to look at some of the health financing issues globally, you can think about how it relates to your own situation. But I think you'll see that in some ways you compare very well, and in other ways there are still challenges in Brazil and in some of the surrounding countries in terms of health financing. Now, health financing has become especially important these days because of the drive for universal coverage, and we know that universal coverage may require some additional resources, but it also may require some additional resources well spent. And economists are interested in additional resources for health, but they want to see what we're going to get for that investment in health. Are we going to get something for it? Are we going to invest it well? And I also have a question to myself, but also a question to you in terms of health financing. We saw historically different paths, different ways of going about financing health, but now I think we may be seeing some convergence globally. And again, it's a question for me, but it's also a question for all of you as to whether this is actually occurring. What I want to talk about here, when I talk about health financing, I'm really talking about three dimensions. A first dimension is where the money comes from, the revenues, and it can come from many different sources, premiums from general revenues, general taxes, but also from earmarked taxes, from payroll contributions, and also from out-of-pocket payments. A second broad dimension is risk pooling. Risk pooling, and here we talk about are we pooling the money in one pool or several pools, how we coordinate across these pools. Dr. Torres talked about fragmentation and coordination, devolution, deconcentration. All of these come very much in play when we talk about risk pooling. And a third dimension generally would be purchasing. And here we talk about the benefits package. We talk about things like contracting, mechanisms like contracting, and also provider payment systems. And many of the speakers have talked about the importance of contracting and provider payment systems over the past couple of days. And of course, the design and organization of these different dimensions of health financing are important because they lead to certain provider behaviors. We want to design and organize and implement dimensions of health financing so that we can have an optimal impact on provider behavior, and also to look at the impact on coverage, the impact on health outcomes and health expenditures. So I'm having this, okay. So I want to look first at where the money comes from, looking at some of the changing global patterns. Again, is there a convergence? And then all of us are interested all the time in looking for more money for health because health is virtually unlimited in terms of demand. And in the bank, we often do a fiscal space analysis with our client countries to see if there might be more that can be generated for health. And we'll talk about that a little bit. And then once the revenues are raised, what are the issues related to equity and allocation? So in the past, there's really been two models that people have talked about in terms of health financing. One is the Bismarck model, after Otto von Bismarck of Germany. And the second is the Beveridge model, named after Mr. Beveridge in the United Kingdom, in England. And here we have different ways of thinking about these two models. One is the basis of enrollment. In the Bismarck model, you are enrolled based on your contribution. In the Beveridge model, you're enrolled on the basis of your citizenship alone, or your residence in a country. So that's one important distinction. A second important distinction is the funding base. In the Bismarck model, it's really wage-based. Money comes from your wages, from some contribution from your wage base. In the Beveridge model, it really comes from general revenues, from general state revenues. The third feature which distinguishes these two models are the insurer. In the Bismarck model, you would really belong to your occupational group. If you're a lawyer or if you're a shoe cobbler, you would be in different groups. And in Beveridge, it's really the state which is the insurer for you, and everyone is in that pool. A fourth feature is the benefits package. In a Bismarck model, it's much more explicit. In the Beveridge model, you tend to define the benefit package by looking at the services that are provided. So it's more implicit. A fifth feature is the management. And in the Bismarck model, you tend to see more autonomous national organizations running the healthcare financing system, whereas in the Beveridge model, it's more aligned or more integrated within the government, organization. So you see this feature as well that distinguishes Bismarck versus Beveridge. And a sixth feature is providers. Providers in the Bismarck model, you might see more in the way of private or private-public. For example, in Germany, about 2/3 of your hospitals are private. And in the Beveridge model, you might tend to see more in the way of public provision. And finally, in terms of purchasing, the Bismarck model has always been associated more with strategic purchasing in the sense of using contracting mechanisms, of paying for outputs, relative to the Beveridge model, which is more inputs and salaries. So these are the 7 features which kind of distinguish these two traditional models. But I think if you now look around the world, you see much more in the way of hybrid models. And here I look first at the high-income countries, and I just take 4 countries in the OECD. The OECD meaning the Organization of Economic Cooperation and Development. The OECD is often called the rich man's club or the high-income country club. And Brazil will be part of that OECD, no doubt, within the near future. In the Americas, who belongs to the OECD? It's Canada, the United States, Mexico, and Chile. And here we just look at some of the models from the OECD, the UK, Canada, Spain, and Denmark, and you can see that their revenues come from general revenues, what we would call the Bismarck model, but in fact, when you look at the pooling, when you look at the contracting, when you look at the strategic purchasing, paying for outputs, the use of contracting, you really see that they're also taking from what we might traditionally call the Bismarck model. So they've evolved into more hybrid models, taking a little bit from Bismarck, taking a little bit from Beveridge. And so I've just highlighted here Canada and Spain. We heard about Canada yesterday, we heard about Spain yesterday, and these are countries that we might be more familiar with. So I'm having the same trouble as the Canadian lady yesterday with the clicker. So the OECD saw this hybrid situation across many countries, and so they decided to look at different system characteristics and try to reorganize them in different ways. And you see how they organize them. They organized them into 6 groups, and then they categorized them, and they said, which of these different hybrid models are actually performing best? Can we tell anything about the characteristics of the systems and how it leads to greater efficiency or a greater improved outcomes. And what they found was that there were well-performing countries, good-performing countries in every category, but also poor-performing countries in every category. And they found that there was really great variation within the groups, much more variation within the groups than across the groups. So at least in the information that they've recently collected on these different hybrid models in the OECD, they don't see any trend or any pattern in terms of outstanding performance. So let's talk about emerging economies and the universal coverage. And there's a long road globally to universality. We see that countries, whether it's in Africa, whether it's in East Asia, whether it's in Latin America, there's a long road to universality. There are some exceptions. I think there are exceptions such as Colombia, which is now above 90% in terms of coverage. There's an exception in terms of Thailand, which went very quickly to almost 100% of universal coverage. But in fact, many countries have a difficult time and a long time to reach universal coverage. Why? Well, in many emerging economies, we see that contributions are linked to coverage. Contributions are linked to coverage, and that often means that for some years, whether it's decades or in the case of Egypt, it's been over 50 years now, where they have a large percentage that remain uncovered. And I just give some countries here. Some are small and some are large, such as Russia, that's relatively decentralized. Egypt, which is relatively decentralized. But whether it's a small country or a large country, you see this pattern of countries getting stuck. And I give some more countries here from East Asia. Again, Vietnam, 80 million people, Philippines, 80 million people, Indonesia, over 100 million people. These are all decentralized health sectors. Russia, again, 60% of the economy is informal. So it's not surprising that they got stuck when they linked contributions to coverage. So that's the first issue. And we often think that as economies grow, formalization will also grow. But that's not always the case, and here I list Indonesia, again, a very large country, over 100 million people, growing quite rapidly, but also very decentralized, has more of a confederation type of situation. And we see that informalization is not increasing even as the economy grows. It's going up a little bit, but just very, very slightly. And so the prediction would be that it's not going to be a highly formalized economy anytime soon. This is a study that was done by someone in the World Bank, Adam Wagstaff, looking at OECD countries, high-income countries that went from a beverage-type health system with general revenues to a Bismarck style. And what happened, he found that when you went to wage contributions, wage-based contributions, that it often hurt employment, it reduced employment, it was essentially a tax on labor, and it also increased the level of informalization in the economy. So these were negative impacts that, that really, while it may have brought in more money into the health system, from a macroeconomic standpoint, it was destabilizing and negative. Now, a second issue is that as countries get older, their revenue base is declining due to the aging and demographics. And here I give one country of the Czech Republic. Obviously, as people move from the productive sector to retirement, the wage base that can be captured for revenues for healthcare decreases. And so this is a problem for any country that has an aging population. Here I give numbers from the IMF, and you can see that there are 3 countries from Latin America where aging will be a real issue in the next 20 years, up till 2030. The third from the left is Brazil, the fourth from the left is Chile, and the fifth from the left is Argentina. And you can see, especially for Chile and for Brazil, that aging is a real issue in terms of a rising cost and pressures to contain cost over the next couple of decades in terms of the expenditures in healthcare. So there are added pressures from the aging and demographics in several countries, including Brazil. So some ideas about what to do. Certainly some countries have gone to increasing general revenues. They've moved away from collecting money from payroll and from the wage-based and gone more to general revenues. Germany, France, China, Thailand, Moldova, both big and small countries from every part of the world. And a second idea is to have some more in the way of earmark taxes. Now, public finance specialists don't like the idea of earmark taxes because it constrains flexibility, but at the same time, many countries, Thailand, Ghana, Laos, have gone to some kind of earmark tax regime as a way of raising more revenues dedicated for health. And I looked at just one way to earmark taxes, and that's taxes on tobacco. And what I found is that all of the BRIC countries aren't doing that well compared to some of the countries in Western Europe, or say the United Kingdom, or Canada, or Thailand. They all have higher taxes on tobacco, and some countries such as Thailand actually earmark those taxes for health, but all of them have higher taxes as a percentage of the price of cigarettes than, say, any of the BRIC countries. And I put Brazil here in red. Brazil is not bad compared to China or India or Russia, but I would still wonder whether there's some room to raise taxes on the price of tobacco products and perhaps earmark them for healthcare services. You see that all of the BRIC countries are doing less well than Chile, for example, just next door. So how much can a country spend on health? The WHO likes to talk about how much you should spend, and the World Bank, in collaboration with the WHO, likes to ask the question slightly differently, which is how much can a country spend on health? And we really break it down using a model from Joe Cutson at the WHO in Geneva. We really break it down into two categories. One is fiscal capacity. Fiscal capacity is basically how much money comes into the government through taxes, through revenues as a share of GDP. That's what we mean by fiscal capacity. And then the second is, what are the public policy priorities? Once that pool of money is available, then how much of a priority is health relative to other sectors, whether it be education or transport or other priorities that all governments face and must make decisions about. In here, we do a regression and we really look at some of the BRIC countries and we look at the fiscal capacity. Now, if you look at South Africa, they do quite well. They do quite well. The money going into the government as a share of GDP is much higher than predicted. What we do here is regress against GDP per capita and also income per capita to see how your country does compared to other countries once you adjust for GDP. So you see Brazil here, which is just about on the line, just about as predicted. Okay, so your fiscal capacity seems okay. It's certainly better than, say, China, certainly better than, say, Russia, and India. So you're doing pretty well that way. But then we go to the second factor which is prioritizing health. And here we look at the percentage of the budget from a country that goes to health. And you can see the global pattern here, and I've highlighted the BRIC countries. And you see that Brazil in the green, and Brazil is not doing very well relative to other countries in terms of prioritizing the share of money that it does have to spend on health, it doesn't spend that much on health. If you look globally, or if you look in comparison with BRIC countries, it does better than India, but it does less well than either China or Russia. So fiscal capacity looks pretty good. That's the first factor. But the second factor, prioritization, doesn't look so good relative to other countries. Now, one thing that countries do now is do a fiscal space analysis. And when you do a fiscal space analysis, you look at the availability of budgetary room for increasing public spending for health without really jeopardizing macroeconomic stability. So we visualize this fiscal space analysis using a spider plot, and I'm going to go through some of the key dimensions. We've already gone through the issue of prioritization, which I've put an arrow to, but we can also look at another dimension, which is the growth, the macroeconomic conditions of a government. And here we've done something for the Russian Federation recently where we looked at GDP growth, and you can see that GDP growth, macroeconomic growth, looks pretty good, looks pretty positive, suggesting there may be some fiscal space in Russia for more spending on health. We also looked at their debt structure, their total external debt as a percentage of GDP. And here we see that they're not doing as well as countries like China and Malaysia and East Asia, but they're doing much better than countries in Europe. They're doing much better than Japan. They're doing much better than the US, which have very, very high debt to GDP ratios. In Japan, I think it's 130%. I think in the US, it's around 90%. In many countries in Western Europe, it's about 100%. So Russia is doing pretty well in terms of total external debt as a percentage of GDP. Now, efficiency is a third factor that we look at. And when you talk about efficiency, the IMF has recently looked at ways to actually improve efficiency globally and thinking about how countries can improve efficiency over the next 20 years. And they find that some mechanisms, some interventions seem to do better than others. A first mechanism is market mechanisms. Now, do they mean privatization? No, they don't mean privatization. What they really mean are integration of incentives into the overall system. Dr. Torres talked about incentives as being integral, and that's what they're talking about here. They find it to be a very effective tool. The second is public management. Public management might be things like good governance, might be pooling of money. It might also be gatekeeping at the primary care level. So public management of services, of the organization of care. And a third intervention that seemed to work very well are overall budget caps for containing cost. So those are the ways that the IMF has found, looking globally, especially in the high-income countries, of interventions that might work or that might improve efficiency, which again will provide more in the way of fiscal space for health spending. Now, we've done something on Brazil, and by the way, we have these one-pager summaries of every country in the world. So if you would like a copy of these, you can just give me your card after the presentation for your country and I can send it to you. But on the left-hand side for Brazil, we show the trends since 1995, the fiscal, the macro, and also the health spending. And on the right, we compare Brazil with your comparator countries in terms of GDP and per capita income. And what jumps out in the fiscal space for Brazil is that you have very good growth. You have very good growth compared to other countries, other similar countries in terms of GDP and per capita income. But you also have a very high debt structure, which means that your fiscal space could be very limited, And in the bottom, you see the spending on health relative to other countries. And again, you're relatively low. You're relatively low, and probably it's due to the relative prioritization factor. But the growth pattern in Brazil suggests that you could have greater fiscal space in the future, and that's a very positive sign. But at the same time, you are burdened by a relatively high debt structure, which I think all of you may know more about that than I do, but these are some clear signals that come up in terms of how policymakers may have to think about spending on healthcare presently and in the near future. So some country cases very quickly. We see a lot of countries going to more in the way of general revenues. Germany, the home of Bismarck, has now gone to a reliance on general revenues, not just on wage contributions. Hungary, if you look very quickly at the red line, you see that over the past 15 years, they have gone from almost nothing in terms of general revenues to something like 50% of spending now comes from general revenues and much less reliance on employers and employees. That's very dramatic. In China, you look at the third insurance organization to the right, which is the rural insurance. They have rapidly scaled up to hundreds of millions of people in the past few years using general revenues, not using wage-based contributions, but using general revenues from the general budget. And you can see the numbers in percentages in the green on the right, and you can see a very dramatic rise. Where does the money come from? The money for this coverage comes in great part from the central government in the blue, the provincial government in the red, and a very small portion coming from the peasant farmer in the yellow. So there is great incentive for local governments to go out and find people and enroll them, because this is all money coming from somewhere else, coming from higher levels, and the farmer has to pay very little for a much richer level of coverage than he or she previously benefited from. So this is the way it's working in China currently. And I think if you look at Brazil, 2008 was the latest year I could get estimates for, but you also see here a confederation in terms of revenues and spending from the federal level, from the state level, from the municipal level. Over 40% is coming from those three levels. So again, you rely on these different levels of government for your revenues here. In India, I'm not sure where India is going. On the one hand, they talk about new insurance schemes for the upper income groups and also for the very poor groups, and they are rapidly scaling up with some of their insurance schemes. But at the same time, there is now a high-level commission coming out with a reform plan that's calling for supply-side financing from the government and not from insurance, not through premiums, not through wage-based contributions, but from the government. So it's not clear to me where India is going because of these conflicting patterns. But regardless, I think we see more in the way of contracting, more in the way of strategic purchasing coming from India, whether it's in the insurance schemes or whether it's from the state plan. Both have indicated very strong interest and need to be strategic in terms of their purchasing, their use of contracting, and their use of new payment systems. So let's talk about, we talked about where the money was coming from, how to get more money in terms of fiscal space. Let's talk about some of the allocations of revenues especially in the bigger, more decentralized, what we might call confederation states. Again, here's Brazil. We saw that before. And I think that a pattern that we see globally, not just in Brazil, but globally, is that there are disparities. There are disparities by region. And here we see Brazil. If you just look at these numbers are a little old. I'm sorry about that. This was the best I could do, but if you just look at some of the numbers here, if you look at the Southeast versus the Northeast, you see expenditures very different, very different. My guess is that that probably still persists, although the numbers have changed. In Russia, big regional disparities, over a 10-fold variation in per capita spending depending on the region that you're in. There are about 88 different regions in Russia, and a very, very big variation in terms of the patterns of spending. In China, a very confused picture. Here is the funds flow in China, and you see it's a very confused picture of funds flows. I commend the person who was actually able to do that, to actually go through the numbers and to figure out the funds flows in China, but this is a very complicated mix. But in the end, when the dust settles, you see huge variations in spending depending on the insurance scheme. So it's like a 10-to-1, similar to Russia, it's a 10-to-1 variation in the spending depending on whether you're in the rich urban scheme or whether you're in the poor rural scheme. You have a much different level of expenditures available to you on average depending on where you live. So even in this convolution of funds flows, when the dust settles, it's a very inequitable look. This is just 2 provinces in China, and you can see that it's not only an urban-rural problem, but it's also within each province. And I take 2 provinces here, a rich province, Jiangsu, and a poor province, Jiangxi, and you can see that they are very, very different in terms of county by county, the per capita spending. And so what the Chinese have said is that they will start to pool money by 2020. They will start to pool money under one provincial level pooling fund, whether you call it an insurance fund or a purchasing fund, and that will happen by 2020, and that should help to equalize those disparities that you see now. Good practices, we see a lot of countries moving to a single payer system. I list some countries here in Eastern Europe, but I also list a BRIC country, which is Russia. Russia last year passed new legislation calling for more in the way of centralization, and then centralization under this single insurance fund, but then a reallocation to provinces on a per capita principle, so there would be greater equity starting next year in Russia. So that's a very positive signal. You also see more in the way of coordination. If you have multiple payers, you still see a coordination body, and I've listed some countries in Europe, a coordination bodies that allow some transfer of funds across insurers for virtual pooling. They set prices across insurers so that you assure access across all of your payers. They set the benefit package so that there's a standard benefit package across all of the payers. And they also regulate the providers and payers so that even if you have multiple insurers, multiple pools of money, you have one regulation body which allows virtual pooling and allocation in an equitable way across the various pools of money. So yesterday we heard how GPs in Great Britain are paid on a per capita principle, but there's also some adjustments for age and gender, and we also heard that in the presentation on Portugal. And you can do that, the same thing, across geographic areas. And here I just list the European countries, what they're doing, and there's a couple of important points here. They use the per capita principle to allocate across geographic regions, but then they also adjust for some key variables that have to do with variations in need. One is age, one is gender, and then there are a couple of others, such as levels of poverty, levels of rurality, and in some cases, outcomes. But you can see that at most they use 6 or 7. I worked in one country where they had 158 adjusters. It's too many. Keep it simple. Keep it to 5 or 6 at the most. Use the per capita principle. You can adjust for 2 or 3 different things, but after 2 or 3 or 4 variables, you find that the impact is very small. and the work is much more, so it's really not worth it. Other considerations when you go to this per capita principle and you have multiple streams of money coming from the federal level, from the state level, from the municipal level, you need to think about your local fiscal capacity to raise funds, to manage funds, and as you develop the formula, you need to think about this broader fiscal situation in terms of the national and regional funds flow. Once you go to a per capita principle, you may find that there's a huge swing in how money is allocated, a huge swing, and so that means that you may need to give people, regions, providers time to adjust, and that may be a multi-year phase-in. And finally, you need to think about a final phase where you might include, you might initiate some new performance indicators. Some of the better performance indicators that we've seen around the world have been paying for improved primary care, paying for more in the way of outpatient services or better outpatient services. Sometimes countries want to go immediately to paying on the basis of outcomes, but that's not always easy because changes in outcomes take time, and changes in outcomes can't always be fully attributable to the healthcare system. We know, for example, that a mother's education correlates very highly with infant mortality and under 5 mortality, and that's not something that has to do with healthcare necessarily. So it's multi-sectoral factors that contribute to better outcomes, and so we can't always include it into the healthcare system. So another approach might be to match, to do some kind of matching formula. We heard yesterday about Canada. They do match. They have matching federal grants to make things more even across provinces, depending on their fiscal capacity. And in the United States, we have one program for the poor, the Medicaid program, which uses a small number of variables, including per capita income, levels of poverty and disability, which really then adds up to the federal government paying some share and the state paying another share. And if you're a poor state like Mississippi, 83% come from the federal level. And if you're a rich state like Massachusetts, only about 17% of your money for Medicaid comes from the federal level. So it's a matching grant system that depends on fiscal capacity and income of the various states. Now, that's the good news in the U.S. The bad news is don't let your system be so confused and convoluted and complicated as the new Obamacare plan is. And this is just a schematic of the Obama plan, and it's wonderful that the United States is now moving towards universal coverage, but politically, they could not do it in a kind of simple and relatively transparent way. And here you basically see the outlines of the funds flow that will occur in the United States under this new accountable care organization that has started to be implemented in recent months. And you thought China was confusing, and now you can see the US is just as confusing. Finally, the World Bank did a book recently where we looked at what good practices we found around the world that linked up with expanded coverage and health reforms. We looked at 8 countries, including Colombia and Chile in Latin America, and we found a number of factors that seemed very important. And we grouped these factors into 3 areas: institutional and societal factors, policy factors, a second dimension, and here I'll just look at a couple of things here. One was consolidation of risk pools, was found to be very important, and another factor was limits to decentralization. Dr. Torres talked about the issues of decentralization and deconcentration, and I think that we found that on the provision side, sometimes deconcentration or decentralization was a good thing, but there were certainly limits to decentralization in terms of financing, and that it could be a negative in terms of too much decentralization when it comes to health financing. So we talk about the limits to decentralization in this book. And then in terms of implementation factors, a third dimension, we talk about efficiency gains, but we also talk about coverage changes that were accompanied by carefully sequenced health service delivery and provider payment reforms. So not only did you want to design, but you want to implement very carefully, and you want to monitor and evaluate as you go along, and make changes as necessary, because every reform in the health sector in the countries where I've worked have so-called unintended consequences, surprises. So it's very important to catch these surprises and to make adjustments as you go along. And if you would like a copy of the presentation, please write to me, and I'll be happy to send it to you. Super obrigado.